and welcome to the Scientific Advisory Board Oral Session number 1. My name is Ines Körner. I'm the outgoing chair of the Scientific Advisory Board, and it is my absolute distinct pleasure today to present to you 4 fantastic researchers who will share with us their science this morning. We will have pre-recorded talks by each speaker, and then we will have time for Q&A. So I invite you all to type your questions for the speaker in the chat during the presentation or afterwards during the Q&A. We have 3 awardees this morning. We're starting out with Dr. Christian Guay, who is the chief resident at Washington University. He is this year's recipient of the Margaret Wood Resident Research Award. And congratulations to Dr. Guay, and let's see your presentation.
Disclosures for this talk include funding from the McDonnell Center for Systems Neuroscience at Washington University in St. Louis, a pending patent on some of the methods that I'm going to discuss, as well as the fact that my presentation does include discussion of the investigational use of a novel device. I'd like to acknowledge my mentors and collaborators at Washington University, as well as MIT and Imperial College London. I'd also like to thank the Association of University Anesthesiologists for recognizing the merit of this project with the Margaret Wood Resident Research Award. So let's start with a brief discussion of EEG slow delta waves. This is probably a familiar sight for many of you. It's an intraoperative monitor during general anesthesia. And what we're seeing at the bottom waveform here is the raw EEG of a patient under sevoflurane anesthesia. And I want to specifically make note of these large amplitude oscillations here in the EEG waveform that are recurring at about 0.5 to 4 hertz frequency. Now, these slow delta waves are not exclusive to general anesthesia. We also see them during N3 sleep, as well as sedation using propofol and dexmedetomidine in the intensive care unit, for example. So to answer the question of whether slow waves are a reflection simply of drug concentrations, because they do increase with increasing drug concentrations or states of consciousness, these 2 papers published in 2018 aroused participants from propofol or dexmedetomidine sedation and looked at what happened in the EEG. And what they found is, despite maintaining steady state concentrations of the drugs using target controlled infusions, the slow wave power in the EEG dramatically decreases as participants transition from a state of sedation to arousal. And this all suggests that the EEG slow waves in fact correlate with states of consciousness rather than just a drug concentration. So of course, then the question arises, can we enhance these slow waves that appear to be associated with unconsciousness non-pharmacologically? And this has been investigated at length in the sleep medicine literature over the last couple of years, where they found that by targeting acoustic stimuli to the peaks of slow waves, they can actually recruit additional neurons to oscillate at this rhythm, thus boosting slow wave power. And you get a lot of downstream effects from this. So it's not just an EEG effect. They're recording increases in memory consolidation, boosting of immune function, as well as a decreased probability of being aroused by ambient noise. And so it really appears that by enhancing slow oscillations, you are enhancing the effects of slow wave sleep. No one has yet tried to take these methods and apply them to slow waves that are not natural sleep. And that was the purpose of launching our trial. So our hypothesis was that in-phase acoustic stimulation of slow EEG oscillations can increase arousal thresholds of humans sedated with dexmedetomidine. This is a figure from our published protocol, again highlighting the fact that our hypothesis focuses on the fact that in-phase stimulation during the upstroke and peak of our slow waves is going to increase arousal compared to our anti-phase stimulation here targeting the troughs, or sham, which is silence. The trial is called closed loop acoustic stimulation during sedation with dexmedetomidine, or Class D. Our intervention here is acoustic stimulation during target controlled infusions of dexmedetomidine, which maintains steady states of dexmedetomidine in plasma and effect sites. It's a within subject crossover controlled trial. Our control here is silence compared to in-phase stimulation. Our anti-phase stimulation really serves as an active control, trying to again show that the phase of the stimulation, the acoustic stimulation, is important, which has been shown during the sleep literature. Our primary outcome is slow wave activity in the EEG between 0.5 and 4 hertz. We're currently blinded to this as the trial is ongoing, so I won't be speaking about that. But what I will speak about is one of our pre-specified secondary outcomes, which consists of arousal thresholds. So this is a quick snapshot of our experimental design. This is actually our first participant. We can see that they're being monitored with our vital signs, standard ASA monitors, in addition to high density EEG with 64 channels. Now, during the experiment, we ask our participants to perform a behavioral task, which is squeezing a dynamometer as they breathe in and releasing it as they breathe out. And that allows us to monitor their state of consciousness as we're titrating up our dexmedetomidine. This is the target controlled infusion device. It allows us to control the pump to maintain steady states of dexmedetomidine. And finally, over here, we have our closed loop acoustic stimulation setup. Now, I want to draw your attention to the right. This is a quantitative sensory tester, and it's been used extensively in the sleep and pain literature, to quantify pain thresholds and heat pain thresholds in awake volunteers and patients. We use it here to quantify arousal thresholds. So what the device consists of is a thermode that we essentially put on our participants' non-dominant forearms when they're sedated and unresponsive at steady state concentrations of dexmedetomidine. We then increase the temperature of the thermode by 1 degree Celsius every second until we induce motion in the participants. We chose motion inspired by Ted Eager's original MAC experiments as a clinically meaningful outcome. Movement, especially seen as we don't have a very accepted measure of consciousness or the contents of consciousness, we thought that movement would be a meaningful outcome. And so that's what we used to stop the temperature and to note the temperature as our arousal threshold. So the participants that we're going to report on today are the 8 first participants in this trial. They were recruited between January and September 2021, all ASA1 patients, all healthy with normal BMIs. So the first question that we wanted to ask ourselves is our phase locking accuracy acceptable? So what we're looking at here are phase histograms of our slow waves. So 0 degrees is our peak, 180 degrees is our trough. And this is the result of 18,000 stimuli, about 1,000 per condition per participant. And what we're seeing toward the light is that in-phase stimuli are being delivered right before the peak, and anti-phase stimuli are being delivered right before the trough of 180 degrees. And so to summarize this slide, the phase locking device is accurately delivering the stimuli, which is good. I'll also quickly note that this phase locking is being done to the FPZ channel, which sits about right here on participants' forehead. We had to choose a single channel. There's nothing magical about this. It's just the most accessible, we think, clinically, and it's what's been used in the sleep literature, but there's nothing to suggest that you can do this with any other part of the scalp. So now looking at our thermal arousal thresholds, now that we know that we've got accurate phase locking, we see that, so these are mean temperatures, like I described before, that were sufficient to induce movement on the behalf of our participants, and you have 95% confidence intervals flanking them. So it took 48.8 degrees on average to induce movement during sham, 48.5 during antiphase, and 50.6 during infant phase. So we were excited to see that there seemed to be a signal, but to quantify the effect size, we subtract the arousal temperature during sham from antiphase and in phase to generate these graphs. And so for every single participant, we generated an effect size, and then this is the mean effect size across participants and the 95% confidence interval of that effect size. And so antiphase compared to sham does not appear, at least with our 8 first participants, to have an effect on arousal thresholds. Whereas in phase increased the arousal threshold by 1.8 degrees Celsius on average, and our interval for 95% confidence ranged from 0.6 to 3 degrees here. And so this is very encouraging because it appears that by providing in-phase acoustic stimulation, we were able to increase the amount of temperature or energy required to induce movement in sedated participants. But 1.8 degrees is somewhat ambiguous to try to interpret clinically. And so we looked into the literature to see what that means. So looking at heat pain tolerance thresholds and heat pain detection thresholds, this is essentially the amount of heat that participants can either detect as being painful or as being tolerant or intolerable, rather. These thresholds can be increased by 1 to 2 degrees by clinically meaningful amounts of opioids. So specifically, what I mean here is by delivering 30 micrograms of epidural fentanyl, your heat pain tolerance threshold, the amount of heat that you can tolerate, is increased by 1 degree Celsius. By increasing that dose to 100 micrograms of epidural fentanyl, you get an increase in that threshold by 2.2 degrees Celsius. Now, 10 milligrams of IV morphine increases the threshold to detect pain by 1.3 degrees Celsius. So although these are not the exact same thresholds that we are using in our experiment, that hasn't been done before, we're the first to do that, they give us a sense of how much pain thresholds are changing in response to clinically meaningful amounts of opioids. And so by thinking back to our 1.8 degrees Celsius, it gives us a sense that this is probably clinically meaningful if you're getting increases of 1 to 2 degrees Celsius with these doses of opioids on these related thresholds. So what are our next steps? First, of course, we want to finish our trial. We have a few participants left to enroll, to finish our analysis, and then to dive into the EEG. So that's our primary outcome. We think that the EEG effects driving these arousal thresholds effects is an increase in slow wave activity. Again, recruiting neurons to oscillate at slow rhythms. However, there may be other effects that we haven't thought of yet, and that's where the high density EEG hopefully will be helpful. Now, once we wrap our head around what we've done with these healthy participants, we would like to start translating these methods into the intensive care unit and ultimately into procedural suites and operating rooms as well. To do this, we're going to have to improve the design of our device. As you saw, our current experimental setup is quite bulky and it's time intensive to set up. Not really feasible to do that in an operating room, maybe a little bit more in an intensive care unit, but ideally what we'd like to have for clinicians down the road is a wireless device that can phase lock acoustic stimuli to multiple different electrodes. There's no reasons why you would need any wires, and they could just sit on the patient's head. At the same time, what we imagine is moving away from simply acoustic stimulation to multiple modalities. In the same way that contemporary anesthesia, especially IV anesthesia, and like total IV anesthetics leverage multiple different drugs with multiple different mechanisms to induce an anesthetic state with less dose of each one of those medications, we envision a multimodal stimulation device that would leverage acoustic, but also electric, magnetic, and ultrasonic stimulation to recruit a maximal amount of neurons to oscillate at these slow rhythms and to enhance our sedation in such a way that we don't need as much drug to maintain immobility during surgery or ventilator tolerance in the intensive care unit, being two examples of clinical endpoints that we would be aiming for. And we don't want to reduce the amount of drugs necessarily because the drugs in and of themselves are neurotoxic or injurious, because that is still very much debated, but there's mounting evidence to show that they're probably not neurotoxic, at least to the degree that we expected previously. But even if that's the case, it's all the side effects, right? So I'm thinking about the patients who do not tolerate sedation because they become hypotensive or bradycardic or apneic. And so by decreasing the amount of systemic pharmacological sedation that we need to use with these targeted neurostimulation modalities, we hope to be able to improve the care that we provide our patients and decrease the amount of side effects that they sustain in response to sedation. And with this, I hope that I was able to provide a good overview of our preliminary results of our ongoing trial. And I'm looking forward to some fruitful discussion. I'm happy to answer questions on this forum, as well as connect via email or via Twitter. And I look forward to future collaborations and really look forward to hearing your thoughts on what we've already done, but especially what we can do in the future together. Thank you.
Fantastic. This is really, really exciting work. Congratulations again, Dr. Guay. We probably have time for only just one or two questions. Audience members, if you have a question for Dr. Guay, please type it now. Otherwise, I obviously have a question for you. I appreciated you providing some clinical correlation for your effect size. That was really helpful. You chose dexmedetomidine for this, and obviously we think that this may be the closest to a sleep state. Do you think can this effect be extrapolated to other anesthetics who may have slightly different EEG fingerprints?
Thanks for the question. I think it's a great question, and I'm seeing Dr. McKinstry-Wu like chuckling because I think he put a very similar question in the chat. Oh, yeah. And it's one that I think we'll have to test empirically. We went for the low-hanging fruit because it has been done in sleep, and so we went for dexmedetomidine, which probably had the highest pretest probability for it. I'm hopeful that it'll work with other sedatives, especially the cocktails of sedatives that people are receiving, right? These are healthy volunteers with a single drug. So it's really clean experiment. Whether we can translate this to other drugs and, especially in critical illness or people in the operating room that are receiving multiple things, I think we just have to test it empirically. I'm optimistic and I hope so, but those are certainly protocols that I'm currently writing up.
Great. Thank you. In the interest of time, let's move on to the next speaker. Thank you again. Our next speaker is Dr. Liz Whitlock, who's an assistant professor at the University of California in San Francisco. She is this year's recipient of the Junior Faculty Research Award for Clinical Science. Congratulations, Dr. Whitlock, and let's see your talk.
On behalf of my colleagues, thank you so much for the opportunity to present our work. I have no disclosures. Postoperative neurocognitive disorder, formerly called POCD, is a feared complication of perioperative care. It's broadly defined as a decrease in cognition, usually memory and/or executive function, which is observed after surgery in 10 to 25% of older adults, depending on how, when, and in whom it's measured. POCD was just defined statistically. PND now includes a requirement for functional impact. But meeting POCD criteria is associated with workforce departure and those still working, functional decline, and death. There have been published calls for discussing PND risk as part of informed consent, but it is still not routinely done. Last year, we published an analysis of memory change before versus after 2 methods of fixing severe coronary artery disease, CABG surgery versus minimally invasive revascularization via PCI. This study used participants in the Health and Retirement Study, a large longitudinal US-based population study of older adults aging in America. We modeled a Z-score-based summary memory score for each participant using direct and proxy cognitive measures obtained during the routine biennial interviews, which occur throughout late life for these participants. Using mixed effects models and an inverse probability of treatment-weighted approach, we found no evidence for a change in rate of memory decline either from pre to post-procedure or any difference on average in long-term cognitive outcomes between those who underwent traditional on-pump CABG versus those who underwent PCI. However, we also identified individuals who underwent CABG and those who had PCI, whose post-procedure memory outcomes were worse than predicted. To align with PND definitions, we measured actual preoperative memory score and predicted the anticipated postoperative memory score based on the average annual rate of cognitive decline in our cohort, analogous to a control group with cardiac disease. Then we Z-scored the actual memory score at the postoperative interview, stratifying into mild PND if the actual memory performance was 1 to 2 standard deviations lower than predicted, or major PND if 2 standard deviations or worse. Roughly 18% of the cohort met the adapted mild PND definition, and 5% met the major PND definition. The research question for this abstract, therefore, was, since CABG and PCI are on average cognitively equivalent, do individual factors predict post-procedural adapted PND definitions? For this study, like I said, we identified participants who had undergone CABG or PCI who met PND definitions, and then built prediction models, leveraging demographic, health, and functional data collected by the HRS that would have been known at the time of the procedure. This included a spate of demographic variables, but also health factors and some functional variables. We used multiple imputation to address small amounts of missing data and ordered and standard logistic regression modeling to create a prediction model. This is an abbreviated table of information that we had about the participants, ordered from no to mild and major PND. Focusing on the major PND group, these participants typically were older and more likely to have baseline difficulties with instrumental activities of daily living and frailty. Off-pump CABG was also somewhat overrepresented, not surprisingly. People in the major PND category were less likely to be male in univariate analysis, and obesity also appeared to be protective. People who went on to meet the major PND definition tended to have lower baseline memory scores, although this was not statistically significant, and tended to undergo their post-procedure interview slightly closer to the time of procedure, so may have had less recovery time. Note also that the median time of PND determination was a bit before 1 year after the procedure, so this is pretty long-term PND considering those definitions. Strikingly, the change in the median memory score from pre to post-procedure was equivalent to about 8 years of cognitive aging in the mild PND group and 25 years of cognitive aging in the major PND group. To put that in context, 8 years of cognitive aging would be like age 65 to 73, which would be expected to be subtle if somebody is successfully aging. But 25 years is 65 to 90, which would probably be clinically significant. In the fully adjusted model, the most important predictors of PND were age, with about 18% increased risk per additional year of age, and off-pump CABG, but not standard CABG. Frailty was associated with a 2-fold increase in PND risk, while being overweight or obese was significantly protective, with odds ratios around 0.6 to 0.7. Here are standard discrimination and calibration data for the model. The area under the receiver operator characteristic curve was about 0.75, and calibration was excellent across the range of predicted NCD probabilities. But let's put this prediction model into better context. If you imagine running this model on all of the participants in the cohort using a 50% cutoff predicted probability of any PND, you would get 2 populations, those who screened low risk, so 88% of the cohort, and those who screened high risk, 12%. If you screen low risk, there's a 96% chance of avoiding major PND and 80% chance of having no PND at all. But if you screen high risk, 2/3 of those participants had PND, and 1 in 4 had major PND. And if we knew what to do about cognitive precautions or some sort of enhanced cognitive related consent, then it might be feasible to do this in only 12% of older adults rather than across the whole population. In conclusion, we present a preliminary approach that we feel is promising for predicting who may be at risk for durable postoperative neurocognitive disorder. The strongest predictors in our model included stuff like age, which is a typical predictor in this area. Frailty and obesity appear to be protective. One of the strengths of this approach using these data are that we have really good representation of participants who've historically been excluded from cognition research. These include people from minoritized race and ethnicity categories, those of low socioeconomic status, and those with baseline low education. One remediable weakness of this approach is that we haven't yet taken advantage of the longitudinal pre-procedure cognition data that we have on most of these participants. We plan to do that with further studies. But one less remediable challenge that we have is that the cognitive testing in the HRS is kind of intrinsically limited. It's only every other year, so that lacks granularity. And the tests include memory, and we're able to get a summary sort of dementia probability, but we have no measures of executive function. And one of the challenges is that cognitive testing is inherently variable. We are confronting issues of regression to the mean, for example, which we hope will get better as we incorporate more longitudinal measures of individual cognitive slope. Thanks so much. I look forward to questions.
I've clearly clicked the mute button one too many times. My apologies. Thank you, and congratulations. Fantastic work. Oh, this is okay. Yes, please type your questions. Dr. Whitlock tells me that she has a case of laryngitis and has lost her voice a little bit, so she may be typing her answers. That should not keep you from asking questions, however. I was struck by your risk factors, especially obesity. I mean, the others I think are not unexpected, as you said, but can you comment on why obesity would protect us from cognitive decline?
There's a really interesting relationship hypothesized between obesity and later cognitive decline. And it may be that declining nutritional status precedes the clinical definition of mild cognitive impairment or Alzheimer's disease. So there are kind of chicken and egg papers about which comes first, the weight loss or the decreased cognition. So we may be picking up people who are in preclinical stages of Alzheimer's disease or other cognitive decline.
That makes sense. That makes sense. Thank you. There's a question by Dr. Ebenson, which I think taps into that also a little bit. Which frailty calculator did you use, and was it dependent on weight and thus possibly confounded?
Yeah, it's more a potential risk for collinearity, Jim. We used a modified version of a frailty questionnaire that has been adapted for use in health and retirement study, and it includes things like unintentional weight loss. So absolutely, that's potentially a collinear factor and something that we're going to work on. But frailty itself has lots of pretest probability that it would be associated with adverse cognitive outcomes, whether they're truly causally attributable to the surgery or simply occur in the same people. Maybe I'll take further questions by text.
Let me throw one more at you. I mean, obviously you hinted at our ability to hopefully target future interventions to the correct patient population. But looking at your risk factors, and do you think are any of these modifiable? Is there any pre-treatment that we could use?
I'm just too tempted to answer this one in person. So this model is explicitly intended only as predictive, not as causal. And it would be very premature to suggest any of these things would be causal. I think what I'm really interested in is identifying who might need an enhanced consent process, who might benefit from enhanced cognitive follow-up postoperatively, that, and then potentially even identifying a population that's at elevated risk for trials of potentially causal, are these people at high risk that we could say, please do this memory intervention before, whatever the cognition thing is that people do on their phones. So perhaps helpful, but I really don't want to extend any of this to a causal implication, because like I said, for the obesity thing, that I think it's impossible to say, please gain 30 pounds and you'll do better cognitively after your surgery.
Thank you. No, that makes perfect sense, and thanks for that perspective. We're moving on to our last speaker of this first session, Dr. Andrew McKinstry-Wu, a assistant professor from the University of Pennsylvania, whose talk was selected as one of our top oral abstracts at this AUA meeting. So congratulations to you.
Hey, I'm Andrew McKinstry-Wu, and today I'd like to talk about the progress my lab has made in identifying the proximate neuronal targets for alpha-2 adrenergic agonist-induced sedation and hypnosis. I'm an assistant professor at Penn. I have no disclosures, and with that, we'll get going. So since alpha-2 agonists produce sedation and hypnosis through the alpha-2A receptor subtype, we created a mouse line with a floxed Adre2A gene, which is the gene that encodes for the alpha-2A receptor. And what this does, it allows for cell-specific knockouts of the alpha-2A receptor through the expression of Cre recombinase in cell types where you want to delete Adre2A. So by crossing our line with other lines expressing Cre under the control of promoters that are specific to adrenergic, subcortical glutamatergic, GABAergic, or a pan-neuronal driver, we create mice that lack alpha-2A adrenergic receptors only in those neuron types in order to determine which of those subtypes alpha-2 agonists are acting directly on to produce their sedative hypnotic effects. So we use loss of writing as our behavioral measure of hypnosis. And we looked at it in response to intraperitoneal dexmedetomidine. We found that if we knocked out the alpha-2A receptor in either in all neurons, in adrenergic neurons, or in subcortical glutamatergic neurons, and that's under the VGLUT2 promoter, it ablated writing reflex in response to dexmedetomidine. In contrast, knocking it out in GABAergic neurons did nothing with as compared to our floxed control animals. So in addition to hypnosis, we were looking at sedation, and we looked at two behavioral measures of sedation: forced and spontaneous movement. In the forced movement test, the mice balanced on a rotorod, and it's a rod that rotates every 60 seconds. And we put them on that rod 15 minutes after giving them dexmedetomidine or saline. And we measured the average time they stay on the rod over 3 one-minute trials. So for this test, the adrenergic alpha-2A knockouts displayed some resistance to the sedative effects of dexmedetomidine and were able to stay on the rod for longer than the wild type controls or the floxed controls. While the subcortical glutamatergic alpha-2A knockouts were profoundly resistant, and they showed basically no effect from drug administration and were as resistant to those effects as the pan-neuronal knockouts. We also looked at spontaneous movement, which we measured for an hour after the rotorod test. And similar to what we found with the rotorod test, the pan-neuronal knockouts and the subcortical glutamatergic alpha-2A knockouts were profoundly resistant to any drug effect from dexmedetomidine and moved around normally. And for this measure, the adrenergic alpha-2A knockouts were actually indistinguishable from our floxed controls. And we're not really certain in this case why the GABAergic alpha-2A knockouts showed more spontaneous movement than the controls or adrenergic alpha-2A knockouts, given that for the other measure of sedation and for our hypnotic measure, they behaved more like the flux controls. We also measured temperature after dexmedetomidine, given the known association with temperature drops with alpha-2 agonist administration. And we found that the subcortical glutamatergic alpha-2A knockouts did not undergo the rapid cooling that you normally associate with alpha-2 agonist administration, while the GABAergic knockouts did, and they actually looked like flux controls. Now, in between were the adrenergic knockouts, which shows slightly less cooling than the controls, but not to the degree of resistance which the subcortical glutamatergic showed. And this sort of very slight resistance, we suspect that rather than active cooling by the preoptic neurons in response to alpha-2 stimulation, and that was previously described by Franks and Wisdom group, that the slight cooling might be related to changes in brown adipose tissue metabolism, so more of a peripheral effect rather than a central effect, but we haven't yet done the necessary experiments to test that theory. We also looked at frontal EEG spectra, and I'm showing some secondary motor cortex EEG spectra here to see whether the behavioral changes that we see are mirrored in the EEG. And I'm giving examples of individual spectrograms here for each genotype before and after dexmedetomidine administration. And in our flux controls, we see the expected increase in delta power and dropout of gamma power. In our adrenergic alpha-2A knockouts, we still do have that drop in gamma power, but less of an increase in the low frequency power compared to the controls. And in both the subcortical glutamatergic alpha-2A knockouts and the pan-neuronal knockouts, we see little of any change in response to dexmedetomidine administration on the in the spectra. And when we look across animals rather than individual examples, and on these graphs, I'm showing on the left the difference between drug and baseline, and on the right the difference normalized to total power. And we see that the flux controls and the adrenergic alpha-2A knockouts do have an increase in delta and decrease in gamma after drug administration, although the adrenergic knockouts are a bit attenuated compared with the controls. And in contrast, the subcortical glutamatergic and the pan-neuronal alpha-2A knockouts show very little changes in power after dexmedetomidine. So on the whole, these changes in the EEG spectra are mirroring what we see behaviorally. And there's the delta and gamma highlighted. So both behaviorally and on EEG, subcortical glutamatergic alpha-2A receptor knockouts appear fully resistant to sedative hypnotic, as well as temperature effects from alpha-2 agonists. Adrenergic alpha-2A knockouts showed a partial resistance to the alpha-2 agonist effects. So taken together, both the adrenergic and subcortical glutamatergic neurons are relevant direct targets for alpha-2 agonist sedation and hypnosis. What's yet to be seen is whether they converge downstream or are synergistic, or how the two pathways converge. And I'd be remiss without thanking my mentors, my collaborators, my extremely talented lab techs and students, and my generous funders as well. So thank you very much, and I am more than happy to take questions.
Thank you. That's excellent, very exciting. Cool mice also. Have you had a chance to fully characterize those mice and their behavioral phenotypes at baseline? I'm specifically curious because of that discrepancy between the spontaneous locomotor response and the balance response on the rotor rod. Are there difference in their baseline behavior at all?
So we haven't looked at, say, baseline sleep yet, or just overall activity patterns. Otherwise, grossly, behaviorally, they are indistinguishable during waking periods from the wild type mice, but quantification of sleep-wake states, of quantified activity, we have not done yet to more fully characterize that.
Yeah, and Dr. Guay is asking similar question about sleep, and I think EEG would be really interesting based on our earlier discussion today.
And that's what we're doing right now. So yeah, that's an excellent
Perfect.
question.
So we'll hear about that next year. I like it. You've obviously tried 2 different doses of dexmedetomidine. Is there a ceiling effect? Would you be able to overcome this if you just dosed higher?
So not with these specific ones, but we've looked at other mice with a impaired alpha 2A receptor, and we've gone extremely high in dosing and have not seen any effects. So while we haven't gone to those extreme doses with these particular lines, and we went as high as I think 4 milligrams per kilogram of dexmedetomidine, still did not see sedative hypnotic effects. And so we haven't specifically tested it in these mouse lines, but we sort of capped it out at 1 milligram per kilogram based on previous experience with mutant lines.
Makes sense. Great. I see, whoops. No, I just lost my chat. Sorry, I just saw another question. Let me find it.
Your chat.
Yeah, Dr.
Yeah,
Bruce
yes.
is asking. Yeah, do you see that question?
I see any other sedative anesthetics. We have solely tested dexmedetomidine with these. We've not started to look at state of volatiles in these mutants yet.
Okay, and there's another one. Have genetic variations in human genomes been identified that mimic your murine model that might cause resistance to alpha-2 agonists?
Most of the variants that have been looked at have actually been, I know they've been studied in psychiatric models with familial history of alpha-2 receptor abnormalities in ADHD. I'm not aware of particularly a cell-specific mutation that occurs with a known human familial equivalent.
Okay. Thank you. I see no further questions at this point, which then concludes our session. Thank you again to all of our speakers for their fantastic work, great presentations, and really stimulating discussions. Thank you to the audience for joining us, for asking questions, for being interested. I invite you all back. We have this year, instead of traditional poster presentations, we have all abstracts that were selected are presented as brief oral presentations in multiple parallel Zoom sessions. We have 2 of these today. One is at 2:15 Eastern, and the other one is at 6 p.m. Eastern time. So I definitely invite you back to join for those. And then we have a member-submitted SAB session at 3:30, and look forward to seeing you all then, and enjoy the meeting. See you later. Thank you.